Pelvis and hip x-ray routines. So as usual, review your anatomy for pelvis, for hip bones, know the terms, all the hip locations, bony landmarks of the pelvis, so topographical landmarks, inner lesser pelvis, hip anatomy, review all those, okay? Also, a visual I want you to recognize as well is the difference between a female pelvis and the male pelvis. So the degree of angle for female pelvis, degree of angle for male pelvis, okay? Internal rotation versus external rotation. We use this in all of hip, femur, and pelvis positioning. The internal rotation drops the lesser trochanter down, and the external rotation, you can visualize the lesser trochanter. The anatomy position of true AP of the knee, leg, and ankle is not the hip. The hip you have to rotate in 15 to 20 degrees medially to put the femoral neck in true AP position. So anatomic position, with the patient with their feet like this, their lesser trochanters are clearly visible, and we don't want that on a pelvis. The relaxed position for most people is this external rotation with the feet out. The lesser trochanters are even more visible. The true AP pelvis position here, it includes, I try to tell my patient to make a triangle with their feet. Toes point in, heels are out, 15 to 20 degrees in, and this places the femoral neck parallel to the IR. You want to see as minimal of the lesser trochanters as possible. Asymmetric rotation is often a visual sign of a hip fracture. When your emergency room patients come in for a pelvis, I look at their feet. Hip fractures present oftentimes with an externally rotated foot of the affected leg, and the leg tends to be shorter than the other. Why? Because the fracture might look like this, and this femur is pushed up higher than the normal. So it presents externally rotated and shorter. Base state pelvis routines, you have a few options. So the routine pelvis order will say 1 or 2 views, and this is usually 1 view of the pelvis. You're going to do 14-17 crosswise. Here's some basic CR pelvis technique, right? If they order a pelvis and a hip combination, it should look like this. XR pelvis with hip, 2 to 3 views, and then it'll say left or it'll say right. You are going to do the AP pelvis and then 2 views of the hip. We call them an AP and a frog lateral. I'll show you that one in a little bit. Up here we have a 3-view order, which is a specialty order. They're going to do an AP pelvis and either Judet views, which are obliques, or the inlet-outlet views, which are tube angles. Pediatric pelvis is routinely an AP pelvis and a frog of AP pelvis, depending on how young they are, or it's an AP pelvis and a frog of just the affected hip. You might see any of those combinations. So AP pelvis, you're going to rotate those lower limbs in 15 to 20 degrees. Make sure you roll from the legs and not just from the feet. Central ray is between the level of ASIS and pubic symphysis. I place the top of my cassette just above iliac crest, and your imaging plate is going to be crosswise 14-17. How do you evaluate AP pelvis? You want the entire AP pelvis on, above the crest, and below the lesser trochanters. Ideally, your toes are rotated in the 15 to 20 degrees so the lesser trochanters are not visible. You want equal visuals of iliac crest. So you want them to look similar and equal to each other. Same with the obturator foramen here, these openings in the pelvis. You want them to look symmetrical. This bilateral frog leg position we don't tend to do routinely at our clinical site. That doesn't mean that you might not see them at one of your offsites, but really similar to that of the AP pelvis, this is an AP of a frog leg. So the femurs are bent at the knees and they're abducted 40 to 45 degrees away from midline. The central ray is 3 inches below ASIS, and it will look sort of like this. So you're looking for frog leg femurs here, so the lateral femur. Okay. What is SCFE? SCFE is an abbreviation for slipped capital femoral epiphysis. It's an unusual disorder of the adolescent hip. It is not rare, but for reasons that are not well understood, the ball at the upper end of the femur slips off in a backward direction. It's due to weakness of the growth plate, and most often it develops during periods of accelerated growth and shortly after the onset of puberty. So as you see in the image here, the femoral head is sitting in line with the femoral neck here, right on the growth plate. If you look over to the right, you can see that the head has slipped forward and off of the growth plate, and the femoral neck is pushed backwards. Here's a normal femoral head and growth plate in normal position in the acetabulum. You can see over here, this is a demonstration of SCFE. You can see the femoral head is off the growth plate and the femoral neck is pushed backwards. Hip routine. For hips at the clinical site, we do an AP and a frog leg lateral. I use a 10 by 12 cassette size. This is an average CR technique for hip. If you're in a trauma hip situation, you would normally do a pelvis to start, and then an AP of the affected side, and then a cross table lateral will be done instead of a frog leg. The technical factors for a cross table lateral hip is much higher than that of a frog leg. So unilateral hip, AP hip, internally rotate the leg 15 to 20 degrees. You're going to use a 10 by 12 cassette. Central ray is perpendicular to mid-femoral neck. Ideally, I don't include this much of the iliac crest. I put the top of my film at ASIS and center down from there. If your patient has a hip replacement, all the hardware must be included. So down to the bottom here, as you can see here, you might need to use a larger cassette due to this plate with screws. You might need to increase your cassette size. Your textbook specifies this location suggestion. It is in your board review. I don't tend to use these landmarks in my clinical practice, but this is something I want you guys to know. So your textbook identifies ASIS and symphysis pubis. You're going to find those 2 points, draw an imaginary line. At the midpoint of that line, you're going to find the point here. You are then going to bring a line down, I believe it's 1.5 inches to 2 inches, and that will land you at the femoral neck. Or you go from ASIS, you go 1 inch to 2 inches medially, and then 3 to 4 inches down is the idea, right? I do not use this method. I put my 10 by 12 cassette, simply the top border of it, at ASIS, and I center midpoint of the leg. And I'll show you both in the lab, and you can find what works for you. Frog leg or a modified Cleaves method. This is a unilateral view, just similar to that of the bilateral view I showed you earlier, but 10 by 12 cassette, still centering at the femoral neck. You're going to bend the patient's knee up and then drop it out to the side, kind of in a frog leg position, 45 degrees from vertical, ideally. For better demonstration of femoral head acetabulum, you can abduct to 90, but we don't often do this view. It's just unnecessary. And this is similar to what it will look like here. We call it a cross table hip, but your textbook uses this terminology, and this will be the terminology that you will see on your board. So axial lateral, inferior superior. Why? Because you're shooting inferior, exiting superior. And this is named the Danielus-Miller method. So this is the trauma hip situation. with a fractured hip, you're not going to frog the patient. You're not going to move that leg that's fractured near the femoral artery. You're going to raise the unaffected leg up, and you're going to shoot across the table, and that's what we call it. The cassette is at an angle here. The central ray will be angled to the grid cassette, and ideally, in a perfect world, this is the view you're going to get here. The modified axiolateral method, we call it the Clements-Nakayama method. This is done for bilateral hip fractures. So if they have broken both hips, and obviously they can't lift a leg up and out of the way to do a cross table. So it uses a double angle. The cassette is angled this way and tilted. The tube has to angle and tilt to match. So it's 30 to 40 degrees medial lateral and 15 to 20 degrees posterior from horizontal. We will do a more in-depth method for this one in our positioning 3 class when we go through trauma situations, but I would like you to know that the modified axiolateral or Clements-Nakayama method is for the bilateral femoral fractures. In a perfect world, this is what it will look like. Obviously, they'll both be fractured. Know your anatomy. Single view chest. In some of your areas, if they have a fractured pelvis or fractured hip and they're going to the OR, they need a chest x-ray prior to surgery. This is not everywhere, but just be aware, if you have an order on a patient for a pelvis and a chest, you always start with the pelvis x-ray first. If the pelvis or hip is fractured, you do not sit the patient up, you'll do a supine chest x-ray. In the OR, you'll see multiple types of hip repairs, depending on if it's screws and a plate coming around the side here. Specialty views, you're going to have outlet and inlet. So outlet view is a Taylor method view. The central ray is 20 to 30 degrees cephalad for males, 30 to 45 for females. Why? Right? Because the shape of the pelvis is different. And central ray is 1 to 2 inches above symphysis pubis. This is what will look like. You'll have really elongated ischial tuberosities here. The obturator foramen will be elongated and magnified. The inlet projection is 40 degrees caudad at the level of ASIS. You have a really sort of oblong shaped pelvis here. I feel like it looks like an alien head, if that helps you visually. But the obturator foramen will be closed here, and they're looking for the pelvic inlet here. The obliques are your other option for specialty views, and we call these the Judet views. These are 45-degree obliques, and we're looking for acetabular fractures. You're going to do one side up and one side down. So we're looking at a side up acetabulum here. You can see how it's magnified because it's raised. The obturator foramen is wide open and magnified because that's raised up. When you roll them down, this is a side down. You have a really kind of elongated iliac crest. The obturator foramen is closed, and you're seeing different visuals. You're either seeing the posterior rim or the anterior rim, depending on which side is up and which side is down. Portable pelvis in the OR, you are centering lower. So do not put your top of your film just above iliac crest like you do for normal pelvis. OR pelvis, you're centering low. Why? Because you want to get just below these prosthesis to be able to see the femur, right? Watch your tube angle and grid angle so you don't get grid lines. The OR pelvis can be done intraoperative or postoperative. You might see both. You can shield males, not females on these for us. How do you evaluate for rotation? You want to see symmetry of the wings here or symmetry of the obturator foramen. Hip dislocations happens often with these prosthetic hips. It's either going to be anterior or posterior. Anterior is rare. Posterior, they're going to be flexed and internally rotated and abducted and adducted. Anterior, the hip is minimally flexed, externally rotated, and markedly abducted. This is the presentation usually.